Good afternoon again. So I'm here to talk about what I mentioned earlier for the abstract, the consideration for actionability and focusing on solid nodules. I have no conflict of interest. So with the expanding low-dose CT screening, new nodules on annual repeat scans are becoming more of the main long-term management challenge. And baseline, we know that occurs only once, and as patient can come back annually, many times over time, nodules found on the repeat scan dominate the workflow. And most of these nodules are going to be benign. So, but distinguishing benign from malignant nodules often require multiple workups and sometimes invasive procedures. So compared to baseline cancers, we know that cancers found on annual repeat may be more aggressive, even at smaller size, and often present as solid nodules. So for this talk, I'm going to focus on solid nodules that we found on annual repeat. So all the nodule management protocol rely on consistency, size, growth to minimize unnecessary workup while diagnosing as many early stage lung cancer as possible. But there's no common metric to compare these protocols. So previously, we have worked on a paper and proposed that using an efficiency ratio to compare these different protocols by looking at the number of participants recommended for a particular workup divided by the number of participants with lung cancer. So this efficiency ratio, ER, the optimum number would be 1. So the higher the ER is, the lower the efficiency. So here is the paper that we published in 2018. Here we find that we compare I-ELCAP protocol to ACR. That's the first version of the ACR lung REDS protocol and the European Consortium protocol. And we found that I-ELCAP recommendations had the lowest efficiency ratio overall for immediate and delayed workup and also for potential biopsies. And when we look at the efficiency ratio for biopsies, which is the number of biopsies performed divided by the number of lung cancer, we found that for I-ELCAP has the lowest efficiency ratio. This is the one step further. Using the I-ELCAP protocol, we show that we can achieve a very high malignancy yield on both baseline and annual, over 90% of the time. So now we know that for all these biopsy cases for all these nodules that recommended for biopsy, actually a majority of them are going to be malignant. So with these good protocol, how can we ask the questions that at what point can we be confident enough that we can actually just go directly to surgery, because biopsy for cases that we recommended for biopsy, majority of them are going to be malignant. So so actionability is the threshold problem at the end. So here's a conceptual framework. Clinical decision-making is anchored in the pretest probability and treatment threshold. So if you see it here, if we have this framework that for a probability of cancers, if we have a threshold that's below this and a low probability of cancer, we can just recommend it at surveillance. And if we have an intermediate probability, maybe we'll recommend biopsy or continue follow-up and get additional imaging workup. And for something that has a very high probability, we can just go directly to surgery. So this is the kind of framework that we are working towards. And then for nodules that have high confidence that they are cancers, especially when biopsy is risky and inconclusive, direct surgery could be a very viable and efficient path. So that leads us to our study. We hypothesized that consistent malignant growth across 3 time points, 3 consecutive CT scans will provide additional diagnostic information and may better differentiate malignant nodules from benign nodules. So the study design is matched case control by matching age, smoking history, the nodule diameter, and follow-up time. we have 57 malignant nodules here and 116 benign nodules. They are all less than 3 centimeters solid nodules. So we look at the measurement at 3 time points, the size on annual repeat, and then look back 1 year ago, that's T-1 for what we call pre-annual, and then the follow-up after the annual, which we call T1. So we use the Bayesian, sequential Bayesian model to model this by using the variable whether at T-1, the nodule can be retrospectively seen, and the first seen size of the nodule, and then the volume doubling time between in the pre-annual and annual scan, and also the volume doubling time between the annual scan and the follow-up scans. And we also categorize the volume doubling time into fast-growing, slow-growing nodules that decrease in size and resolved. So this is the structure of the sequential Bayesian model. The first model include only whether the nodules can be retrospectively seen on the prior scan and also the size of the nodule when first seen. And sequentially, the second model will add additional information to the first model by adding the doubling time of between the T-1 and T0. And the third model continuously and adding additional information for the volume doubling time category between T0 to T1. So what we found was the malignant nodules were substantially more likely to be retrospectively seen on the prior scan, and the benign nodules, 74% of the malignant nodule can be seen retrospectively compared to 20%, and substantial growth for cases that show substantial growth across 3 time points, majority of them are malignant nodules. So this is a pretty busy slide. It shows all the odds ratio for all 3 models. Here, the top above the gray, it shows the odds ratio by including those just 2 variables, and then the gray zone is the model 2, and the bottom one is model 3. But in summary, nodules that can be retrospectively seen was significantly has a high odds of malignancy across all models. When a nodule showed fast growing, it markedly increased the odds ratio of malignancy, and slow growing nodules also increased, but it's not as much as the fast growing nodule. And persistent growth across both intervals of T0 and T1 was strongly associated with malignancy. So here also show the area under the curve. We show that as we increase information from additional information from the scans, how the AUC can increase from 0.72 to 0.75 and all the way to 0.97 in the final model. And so this is the framework that what we're hoping to get at. This is an example of a retrospectively seen nodule. We are getting a probability of malignancy of 64%. As we get an additional time point, we find out that the nodule is fast growing, the probability will increase to 92%. If that time point it shows slow growing, it will be 66%, just increasing slightly. If it's stable, then the probability drop to 31%. And similarly, if the second scan, the probability of malignancy also changes. So what is not being shown here is the confidence interval. On top of these predicted probability is uncertainty. So there can be confidence interval that's wide around these time point, and also that can be confidence intervals that's very narrow. So what we think that we can do with this framework is if we have a threshold and we know the confidence interval, we'll be able to recommend whether a case should be under surveillance, biopsy, additional imaging, or just going directly to surgery. In summary, these protocols can achieve very high diagnostic efficiency while limiting unnecessary invasive procedures, rapid growth across 2 time points, provide additional information, and can shift a nodule across actionability threshold. When predicted malignancy probability is very high and the uncertainty is very narrow, we can just forego biopsy because it's adding very little incremental value, and we can go directly to surgery. And our next challenge will be to further improve this risk stratification for slow-growing nodule, and also balancing the waiting time versus intervention. This framework, we believe, is especially relevant in settings where biopsy is risky, inconclusive, and also limited resources settings, and future management should move forward towards integrated, evidence-based, minimally invasive pathway that personalized decision. Thank you.